The problem is that every time you move data, you introduce risk. Something is likely to happen. In order to manage that risk, you have to take certain other steps. One of the most common ones is you put redundancy in the system. Well, now I have my admit data in my admitting system. I have my admit data in my lab system. I also have that same data in the pharmacy system, and I have the same data in the radiology system. That, over time, gets very expensive and plus difficult to keep in sync as you go forward. You have to introduce error checking algorithms to make sure the data goes where it's supposed to go to get there. You're working all the time to make sure that the data is as close to real time as possible. And of course, it doesn't solve the problem of what we call semantic interoperability. The meaning of the data in the initial system may be lost as you go to the next system. Now, let me give you an example. Everybody take out a pencil. I'm going to deputize you all as physicians. And you are sitting across from the patient. And you're asking the patient some questions. And one of the responses that you write down for that the patient, that is your observation, has 4 letters, C-O-L-D. So if you write down C-O-L-D, that piece of data now gets transferred from one system to another. What is that meaning of that term? Well, it could mean it was cold. I mean, the room was a little chilly. It could mean that the patient had a cold, a viral infection. It could mean that the patient was emotionally distant. It could mean that they had chronic obstructive lung disease. Huge difference in context based on the representation of a single word. Think about that. When you think about all the thousands of medical terms that are being moved around, are we in danger of losing the context of how that data was captured initially? A huge IT challenge. I would argue the greatest barrier to interoperability really is not so much the standards process, it is architecture. This is a picture of what virtually every commercial clinical system offered on the marketplace today actually looks like. And what you can see here is we have all these systems. We're moving this data into some kind of central repository. Customers look at it through a presentation layer. It's a challenge to add new data sources. The data could be replicated, as I mentioned. The data model has to be fairly rigid in order to maintain integrity. If you look at a services-oriented architecture model, you end up with what's called a virtual clinical repository. So whether the data comes from one source or another, it can be, as we say in the services business, exposed and then consumed. It's not moved. And when you realize that you're not going to have to move data around the place, your problem of IT management becomes enormously simplified. The biggest challenge we have is to have the vendor community and the experts in IT who have built their careers around this kind of architecture actually recognize that it may be time to think about an alternative and perhaps a new paradigm for the business that we're in. So what are we doing at MD Anderson? We made a decision several years ago that because of who we are, how we operate, how we integrate research and clinical care, we really had to take on in-house software development, and that's what we have done. We have products called Clinic Station, Rad Station for the radiologist, Path Station, Tissue Station, Research Station, all built on the same services-oriented architecture model. You hear comments that, well, the SOA doesn't really scale, that there are performance issues. Well, frankly, we respectfully disagree. We do over 325 million service calls every month, sometimes as many as 3,000 to 4,000 per second in order to get this environment managed. We have a fully implemented services-oriented architecture. There are case studies on this that have been published by Microsoft and by Avanade. And by the way, although our clinical side is built in the .NET framework from Microsoft, our research side is open source, Java. And it doesn't make any difference because we can expose that data and consume it without having to move it between different kinds of code bases, libraries, etc. But you have to face the fact that you're going to have to deal with increased computational resources for processing and storage. And those are huge issues in healthcare that are only going to get worse, I can virtually guarantee you. Managing complexity is in part a computational challenge. It's in part an intellectual challenge. One of the panelists mentioned about the problems of knowledge engineers and the domain of harmonizing standards and things. Those are not necessarily computational tasks, but they certainly will rely on computational capabilities. Validation doesn't require just standard operating procedures. It really requires, for many of our organizations, a change in how we think about work process and workflow. And I would argue that that is in fact a more difficult challenge, making those changes, than the technology underneath it. Ironically, I'm trained as a sociologist, not a computer scientist and not a biologist, because it turns out that many of the issues that we have in information technology are about the organizations and their use. Now you heard the comment, I'm sure many times, technology itself has no value. Value from a technology investment only comes from how you use it. If we put a PC on every table here today, it would be useless. If you tried to do something with it, now you begin to see the value. That is in large measure a sociological challenge, much more than it is a technical challenge.